طيب, الcase number 1. We have a patient who is 30-year-old male. He has -3 diopter sphere, both eyes, and the best corrected visual acuity is 20/20. طيب. الآن, this is the topography of the patient. We can see the right eye. Always, when we check the topography, we have to see both eyes. We cannot make a decision based on only one eye. The other point, the first thing to look at is the symmetry. We look at the symmetry, superior, posterior, superior, inferior. We look at the symmetry as well, nasal and temporal, taking into consideration that even the normal cornea is asymmetric horizontally. All right? So the most important is the vertical asymmetry if it is there. So as you see here, the symmetry, it is symmetric because the upper part is almost same to the lower part using the anterior sagittal curvature map. And in order to check it better, we have to look at the two opposing points on the second circle of numbers. This is the superior, which is 46 point something, and here 46.8. So if the inferior is larger than the superior by more than 1.4, in this case, we say this is inferior-superior asymmetry. And there is an evidence for that, evidence-based. While if the superior is larger than the inferior, no longer we can consider it more than 2.5, as in my old YouTube presentations, because I couldn't find an evidence for that. So from now on, we will consider only when the inferior one is larger than the superior one, and the value is more than 1.4 as a difference. Then we look at the elevation maps. The elevation maps can be displayed either by the best fit sphere or the best fit toric ellipsoid. The best fit toric ellipsoid can be seen by the holiday report, as we will see it later. So first, this is the anterior and this is the posterior. Since it is best fit sphere, we have to look at the thinnest location, which is the empty circle, as you see here, thinnest location. And we look at the number which is adjacent to it. Here it is +5, here it is +8. To say it is normal or abnormal, you know the cutoff values. I'm sure that all of you know the cutoff values. And of course, the cutoff values differ whether the patient is emmetropic and myopic, or if the patient is hyperopic or mixed astigmatism, because they are different in numbers. Okay, then we look at the thinnest location, the corneal thickness at the thinnest location, as we see here. Here it is 5:1, which is more than 500. Always when it is between 470 and 500, let's say it's borderline, but if it is less than 470, we have to consider it abnormal. Some populations like North Africa, they have thin corneas. For example, they have the 470 as if we have our corneas 530, for example. That's why they have, they do, for example, the BRK even for people having 450. But I don't agree with this because we have always to stay on the safe side. We look at the KM, which is the K1 plus K2 divided by 2. So it is K average or K mean. If we are using the pentacam, it should be less than 48. We don't look at the Kmax anymore because it is prone to artifacts. Any problem in the tears, if there is any scar, if the lid has ptosis, if the lashes are long, all of that will create false Kmax. So we just take into consideration the Km because this is evidence-based, and it should be in pentacam, it should be less than 48. While if you are using other machines that use the Placido, whenever there is Placido, the Km should be less than 47.2. All right, this is the right eye. As we see, everything is fine. Of course, we have to look at the shape of the corneal thickness. No need to look at numbers here. Just look at the shape, whether it is concentric or displaced downward, like dome shape, for example, or bell shape that we can see it in the pellucid marginal degeneration. All right, but we don't look at numbers, opposing points anymore because there is no evidence for that. Here is the holiday report, and we need it always. We need it for two reasons. As I told you, best fit toric ellipsoid, and be careful always, it should be 8 millimeter. Even for the best fit sphere, should be for the 8 millimeter. Now,
Just
we
so
have
the note, it is like filled these kind of BKP.
Sorry, any question?
That's all, Dr. But please just to announce, please, all to be on mute, please. تفضل دكتور مازن.
Yeah. So chord mu is very important because it represents angle alpha, which is important for implantation of trifocals. If you are planning for a cataract surgery or clear lens extraction, you need this value, and it should be less than 0.4, okay, millimeter, 0.4 millimeter, or let's say 0.42, 420 microns. It should be less. Otherwise, if it is high, then the patient most probably will develop dysphotopsia after the operation. Bell-Ambrosia display is very important as well because it is like an alarming sign, okay? It is an alert. If you see yellow or red, you have to recheck all the maps again and recheck the patient on the slit lamp because maybe there is some haze, adenovirus, whatever, scar, whatever, that we missed in the initial checkup on the slit lamp because in a hurry, too much patients, sometimes we may miss something. So whenever you see such colors, then of course in the maps on the bottom, because these maps are for the difference before, after the modification of the best fit sphere, so on. So if you see no green, complete green, then you have to recheck. In addition, this one is good to check the spatial profile and to check that the red line is consistent with the dotted lines. The dotted lines are for the normative data. If it is consistent with it, as you see here, then it means that the thickness is going smoothly from the thinnest location to the periphery without any quick change, as in keratoconus or ectatic corneal diseases. So this one is the normal one. And if you find quick slope going down quickly, then maybe it is ectatic disease. And if you see it going up, maybe it is pellucid marginal degeneration. And if you see it going flat, then most probably it is a diseased thick cornea, not normal thick cornea, because normal thick cornea even will have consistent. But if it is diseased like Fuchs, dystrophy, guttata, corneal edema, whatever, then you will find it flat. You look at the average as well. It should be less than 1.2 to say it is normal. Here, some indices of the D indices. If you see red or yellow of any of them, you have to be careful. You have to check whether the patient has something or not. All right. And here, as you see, you have to check. If the patient is myopic, this should be clicked. If the patient is hyperopic or mixed astigmatism, then this one should be clicked. Okay, this one for myopic and normal, so emmetropic, and this one for hyperopic and mixed astigmatism, because the values will differ. These values will differ. So knowing the refraction of the patient before telling this is normal or abnormal is very important. We come to Zernike analysis. Why we need Zernike analysis? We need it for two reasons. If you are planning for laser vision correction, you have to understand the symptoms that the patient is suffering from. Maybe some patients say I don't like driving at night, although I see good with glasses. When you go deeper with questions, you will find that they are suffering from, for example, halos or starbursts or shadows because of the coma. When the patient describes something as tailed, so it is coma. When the august images, then it's coma. When the patient describes it at halos, then it is spherical aberration. So if the patient says it is like a comet or tailed or a shadow or ghost images, remember the comma. This is the comma. Okay, remember the comma. If the patient says, I see halos around the lights, then remember the spherical aberration. And if the patient says, I see like streaks going out from the spotlights, which is the starbursts, okay? So remember the trefoil. This is the trefoil. Now, how to study the Zernike analysis? So easy. Remember to adjust the settings of the machine, maximum diameter 6 millimeter. This one should be 6. And you have to be sure that the last one is clicked, not any one of those, because this one for front, this one for back, this one for wavefront, that one for surface elevation. We want this one, which is the wavefront of the anterior and posterior corneal surfaces all together. Then click all off. After that, you go to N3, you click it, so they will be chosen, and you click the center of N4, okay? These are vertical trefoil, vertical comma, horizontal trefoil, and spherical aberration. So we need only these 5 high-order aberrations. And here you will see the RMS of those 5 high-order aberrations, okay? And Z40, this is not Z40, it is Z40. It is the spherical aberration, okay? You will find the amount of the spherical aberration itself. This one RMS, but this one is given by Zernike coefficient. So you may find minus or nothing. Nothing means plus. So this one is suffering from, or not suffering because it's normal, but this patient has plus 0.24 spherical aberration, which is positive spherical aberration. If you see it minus, then it is minus spherical aberration, negative spherical aberration. Okay, so all what you need is N3 and the center of N4. Just for more information, the N2 is the lower order aberrations. This is the defocus, which is associated with the myopia or hypermetropia. If you see this number in plus, so there is no sign, it's in plus. So the patient is hyperopic. And if you see it in minus, so the patient is myopic. So here you can discover that I was cheating when I put that the patient was -3. It is like just an example. I put it as an example. So here, if the patient is myopic, you will find it in minus. This is the defocus. And this one is for astigmatism. Look, the patient has horizontal astigmatism, high horizontal astigmatism, as you see. Okay, so this is for the Zernike analysis. As you see, so far, this patient is very normal. Now look at this. RMS, the cutoff value is 0.35 microns. You have to be sure it is displayed in microns, not in diopters. So 0.35. And when it is between 0.35 and 0.5, it is borderline. Whenever it is more than 0.5, it is abnormal. So what? If it is less than 0.35, you can implant trifocal or EDOF or enhanced monofocal. If it is between 0.35 and 0.5, you can implant all except trifocal. If it is more than 0.5, you can implant only enhanced monofocal. Okay? in this eye, not necessarily to be both eyes together. So in this eye, you can implant this or that or this, and you can make another decision maybe in the other eye if it has different RMS. Okay, and this can explain as well the symptoms of the patient, so that if you are planning for LASIK, laser, SMILE, whatever, you can decide whether the patient needs customized laser vision correction or not to address the coma, for example, to address the spherical aberration, for example. So ask the patient about their symptoms. Accordingly, you can correlate that with the Zernike analysis, and then you can understand and decide whether the patient will go for standard laser vision correction or customized one. Now, these cutoff values, the 0.35 and 0.5, are just for the Pentacam and Galilei, because in both you can select these 5 high order aberrations, but in MS39 and Cyrus, you cannot select. It will give you all together, except the low order, of course. So in this case, we will raise the bar. We will consider it as 0.5 instead of 0.35, and 0.7 instead of 0.5. So just shift it up a little bit in order to accommodate the full high order aberrations, because the machine is built like this. This is the left eye, and as you see, there is symmetry and thinnest location here, +3, very good. Concentric, more than 500, average less than 48. And here, I forgot to tell that for the best fit toric ellipsoid, we don't look at the thinnest location. We look at any number within the central 5 millimeter zone. We look at the central zone, 5 millimeter. You can go to the settings here, click, and it will show you if you wish to choose the 5 millimeter circle. So the 5 millimeter circle will be displayed here. So you look at any number within it. If it is plus, more than plus at 12 for the anterior, and more than 15, plus 15 for the posterior. If it is more, then it is abnormal. If it is less, then it is normal. And plus, not minus. For example, here you see minus, we don't care. So you have to check best fit toric ellipsoid and best fit sphere together, because if anyone is abnormal, it means that the cornea is abnormal. Both should be normal to say the cornea is normal. And look at this, chord mu is 0.44. The machine immediately gave it in yellow. Now, how it comes that one eye is normal and the other eye is not? Most probably the patient was not fixating well during taking the capture. Maybe there was some misalignment. So in this case, you have to repeat. And if it continues, then it is one of the rare cases where angle alpha is asymmetric. Some natural or variations, let's say natural variations. Okay, the same here, nothing, consistent, less than 1.2. All parameters are okay. Zernike analysis, it should be 6 millimeter. This one, all of N3, center of N4, RMS is 0.274, so nothing. Z40, almost nothing. And by the way, the cutoff values for the RMS of those 5, as we mentioned, 0.35, 0.5, and for every individual one, the same. Okay, don't think that, okay, individual, so maybe the cutoff values should be less or more or something. No, the cutoff value for the coma is 0.35. The cutoff value for the trefoil is 0.35. For the spherical aberration, 0.35. Altogether, 0.35, like this. All right, so this one, -3, 10. Is he eligible for refractive surgery? I think you will say yes. Okay, I'm answering on behalf of you because it is straightforward. But for the next cases, you have to answer in the chat. We will see who says yes, who says no. Any question so far before we move to case number 2?
يعطيك العافية دكتور مازن. في عندنا كان question about the spherical aberration. كان يسألون عن what is the cut value.
Yeah.
يعني what is the acceptable amount of spherical aberration?
Yeah, it should be less than 0.35, but up to 0.5 is okay. And by the way, the spherical aberration in the cornea is helpful for us to decide which type of lens to put inside if we are planning for monofocal. Because, you know, there are some monofocals which generate a negative spherical aberration of minus 0.27, 26 something. And some, they are neutral, aspheric neutral. So they generate 0. And those lenses, we put them in keratoconus because any decentration will not affect. And the very old ones that we were using maybe 20 years ago, and they are still here, they induce plus spherical aberration, about plus 0.15 microns, which are very helpful if the patient has high minus spherical aberration in the cornea, and we want to compensate it to bring it down to make the vision sharper. All right? So that's it.
في سؤال ثاني يا دكتور عن يعني would you take the value of Q value من ال Z40 ولا تبي تاخذها من ال Q value اللي موجودة في البنتاكام اللي موجودة في الفورمات ديسبلاي؟
Yeah, okay. Now, this is the Q values. It should be 6 millimeter here. Be sure that it is 6 millimeter. And I think it's 8 here, 8 millimeter. So this is not correct. Anyhow, the Q value does not necessarily represent the amount of spherical aberration because the spherical aberration correlates to the Q value and correlates to the radius of curvature. So 2 factors. So you cannot say if Q value is like this, then spherical aberration is like this. You cannot say that. There are 2 factors correlating to the Q value. Spherical aberration and radius of curvature, the K readings. In other words, the K readings. So if you want the Q value, you can take it from here, but be sure it is 6 millimeter. And if you want the spherical aberration, you can take it from here. This one, spherical aberration, or from here. This one is just like this one. Okay?
So the question is, do we need to go to the Zernike to double check the Q value, or is it enough just to take the one on the format if it was at 6 millimeter?
Q value is not given by Zernike. Zernike gives spherical aberration. If you want the Q value, you have to go to the 4 maps. Here, it is here.
And the next question is, there's the RMS value. Can you repeat the relation between it and the trifocal?
Yeah. Now, if you have less than 0.35, you can implant trifocal because you are happy that the patient most probably will not develop dysphotopsia after the operation. If it is between 0.35 and 0.5, most probably, the patient will develop dysphotopsia. So better to avoid the trifocal. If it is more than 0.5, it is maybe definitely that the patient will develop dysphotopsia, so avoid it. After 0.5, you have to avoid it. Now, the EDOF lenses are more forgiving. You can use them happily when the RMS is between 0.35 and 0.5, and of course, if it is less than 0.35. So they are more forgiving. But if it is more than 0.5, it's better to avoid the EDOF. And of course, these 2 values, shift them up if you use the CSO, Cyrus, or MS39. shift them up to be 0.5 and 0.7.
واضح. You can proceed.
طيب, this is case number 2, 45 female plus 3, 10. Okay. Oops. Sorry for this. Let me see if I can. Yeah, I can change it like this. Good. Fine. This patient has 44.1, 44.8, so less than 1.5. Here, thinnest location, 0.7 and 0.16. Because it is hyperopic, both are normal. Concentric, 583. Very good. The Km is 44.4. Now remember, the Km is important when we want to treat by laser vision correction, because if we want to treat the +3, they will increase the
ستحتاج إلى فتح قفل آيفون أو
the 44.4 will be increased by 3 diopters multiplied by 1.2. So 3.6. So you will add 3.6 to the 44.4, so it will be 48. Okay, you will end up with post-operative Km 48. That will be fine, because it's better not to go higher than 48 post-operatively, or 49 maximum. Otherwise, the patient will start developing spherical aberration. And it is important as well for patients for myopia, because myopia will reduce, every 1 diopter of myopia will reduce the Km by 0.8. So let's assume that the patient has 5 diopters, multiply it by 0.8. So the Km will be reduced by 4 diopters. So the post-op will be 40.4. Okay, you deduct 4. So by this, you can predict the post-op Km. If the Km between 34, or better 35, and 48, then the spherical aberration, the induced spherical aberration, will be minimum. Otherwise, it will be very high. And of course, this is not only the factor, because even if you make, for example, the K readings 40 after the operation, but you make it very small optical zone, the patient will suffer from spherical aberration. So it is not only related to the Km, it is related as well to the optical zone that you are treating. But this is just to know your limit in the amount. For example, patient coming with -8, and the K readings are 39, for example. So in this case, maybe you will end up with 34 and below, which is not good. So this is why the Km, we need it. Now, don't look at the shape. The tongue-like extension is no longer used. It shows just that the cornea is distorted, maybe because it's a large angle kappa. When there is large angle kappa, you will find this shape, although the cornea is symmetric and fine and normal. So the tongue-like extension is not a risk factor. The best fit toric ellipsoid is fine. Now look at this. The best fit toric ellipsoid, more than +15. Although the best fit sphere is normal. So that's why we have to both. We have to both. And here, Corneal is fine. Look at the BAD. BAD, there is something. And look at the slope. It's going consistent. Then suddenly after 4, it goes down. And then it goes up. So our reference is the 6 millimeter. If it goes down before the 6 millimeter, then it is abnormal. Here, the average is normal. Here, red colors and blue something, so sorry, yellow. So the elevation maps are abnormal. Is that true? Who can say what's the wrong with this? What is the wrong with this map? We cannot depend on this map. Why? There was a mistake. Who can say? Can you hear me?
ايوه اسمعك دكتور بس انا قاعد انتظر احد يجاوب.
No. Indeed, the patient has hypermetropia, while here it is clicked as myopia. So we cannot depend on these numbers. We have to click on the hypermetropia and check whether they are still there or not. In many cases, when there is mild distortion, it will disappear when you choose the correct one. But whenever it's severe, you will find it, maybe the change will be just minor. Now look at this. This is the myopic. Now I'm going to click the hyperopic one, as you see here. The hyperopic. Now the numbers became less. The final D is 1.75, while it was 2.03. So it is less abnormal, but still abnormal. So always be careful to choose the correct one.
It
Now,
was answered دكتور في الشات بس انا ما شفتها.
very good, very good, mashallah. Now here, the patient suffers from, does the patient suffer from anything? Spherical aberration, trefoil, coma, what do you think?
انت تشوف الكومنتس دكتور ولا ما تظهر معك؟
لا ما بيظهروا عندي والله سبحان الله. لحظة
اوكي
شوي.
انا اقرا فيها. اوكي
لا لا
اوكي سو الان ظهرت. اوكي
okay. Comma. Some people say comma. Okay, let's see. First of all, the RMS 0.343, so it is within normal. Let's go for those things. The comma is here. This is vertical comma. It is minus 0.153, so normal. The horizontal is minus 0.284, also normal. So actually, the patient doesn't suffer from anything, but very good, Abdurrahman. Thank you for the trial. And here, as you see, look at this skewed radial axis. It should be less than 22 degrees between the central part here, this one and this one. And the astigmatism of the anterior surface should be more than 1.5. If it is less than 1.5, then don't consider this one. Ignore it. So the skewed radial axis is important when this one is 1.5 and above. So here it is not important. Thinnest location, corresponding numbers, +8, and here +19. For the posterior up to 28, it's not a problem because the patient is hyperopic. Okay, so it is normal, but the tongue-like extension, most probably because of large angle kappa. Here, Corneal is normal. Any number here is normal. Here, any number is less than +15. So for the left eye, the elevation maps are fine, while the BAD shows no, they are not fine. So sometimes the BAD may give false positives, especially in case of large angle kappa. Now look at the spatial profile. It goes down before the 6 millimeter. So this is abnormal. And here the average, although it is less than 1.2, maybe the machine will give you yellow between 1.1 and 1.2. And we have some other parameters here, but we have to click the hyperopic and here are the hypo, still abnormal. So we have this patient with suspicious elevation maps. There is nothing specific. We cannot say it is keratoconus. All right. Here, the patient, same. The patient does not suffer from anything. RMS less than 0.35. All are less than 0.35. So, is she eligible for refractive surgery? Taking into consideration the age, 45 and plus. You can write in the chat just yes or no. Is she eligible for laser vision correction, laser, whether it is LASIK or PRK? Who says yes, who says no?
والله اختلف العلماء يا دكتور.
اختلف الفقهاء. هلا حنشوف يعني okay. طيب, let us see. Now, if we go for very thin flap, 100 micron, the patient is 581 micron. So we have very beautiful thickness. And if we make the cut very superficial, and we know that the plus will not take any tissue from the center, so all of that will be nice and smooth. But if we go for that, then there is a monster hiding on the posterior surface. Okay? This monster is bulging on the posterior surface, is waiting somebody to come and cut the shield of the anterior stroma of the cornea in order to bulge out. Immediately it will bulge out unpredictably, which means it may bulge out centrally, making something similar to the cone, or maybe on the side. So the patient will suffer from irregular cornea and coma and blah, blah, blah. Whenever you see something on the posterior surface, even if it is suspicious, don't touch the cornea. This is the rule. Otherwise, you will make a disaster. And I'm talking from my experience, because when I started refractive surgery about 20 years ago, even more, in 2000, so 24, of course, there were no rules. The topography was very silly. It was just Placido with some colors here and there. There were no elevation maps, even no corneal thickness map. We used to do it by ultrasound. And then the patient comes up with disasters. We don't know why. Although the anterior curvature map is very beautiful. After the operation, we come with irregular cornea. And this is very specifically in hyperopic treatments. And then in 2005, when I started having the pentacam and so on, we could start understanding what's going on the posterior surface, anterior surface, elevation maps, and I stopped doing anything without checking the posterior elevation map in both the best fit toric ellipsoid and best fit sphere. So now, okay, what to do? This lady is crying. She hates her life. She doesn't like 2 pairs of glasses, both are plus, and she is not happy with the progressive lenses. So what to do? Okay. Okay, lens-based. We have 2 options, of course. Either clear lens extraction, which I call it clear baby extraction, all right, because this is a gift from God that we are taking out. But of course, in some cases, we may do that, especially in plus, when we cannot do LASIK, but not in minus, definitely. or we can go for ICL. But ICL in age of 45, I don't know whether any of our colleagues here agrees with me or not. Usually after age of 45 and above, no ICL, usually. Or definitely for me always, but I don't know for the colleagues. What do you think, Dr. Mahanna?
Yeah, definitely above 45. I don't think it is also FDA approved above 45, at least these ICLs that we have now, unless we are going to have the new EDOF ICL. Maybe we may extend the age, but the nowadays ICL, yeah, totally agree. Above 45, we should not.
Very good. Type, okay, great. Now let's move to the case number 3. 20-year-old female, -1 minus 140, -1 minus 1 110. Now, what is suspicious in this slide? Please write in the chat. What do you think? We have 1, 2, 3, 4. 4 suspicious points. The axis, good, against the rule, perfect. What else? Age, 20, young. Very good, not mirror image. Perfect, Rasha. And female, hormones. Therefore, we have to think about ectasia, keratoconus maybe. So, as you see, 20, 40, and 110. What is the flat axis of the right eye? Write a number, please. What is the flat axis of the right eye? 40. Who says else, something else? Okay. Yes, it is 40. Wherever you see minus cylinder, then immediately the axis is flat. Okay? So the left eye, the flat axis is 110. That's why it is against the rule. The right eye is oblique astigmatism. Good. Here we see it is very suspicious. And numbers are okay, but you feel uncomfortable. Although, if you look at this number and this number, there is no difference, but the shape itself is something uncomfortable. And the thickness, 483. All right. How about the best fit toric ellipsoid are okay. Chord mu is fine. Belen Ambrosio chose something abnormal because it's myopic. It shows these things abnormal. And although it is consistent, but immediately after the 6, it goes down. We can consider it normal, of course. But as you see, it is a collection of some things annoying. Here, the patient is suffering from some higher order aberration. Correct? Type. Which higher order aberration is making this problem? What is the one? The highest one. This is horizontal trefoil, horizontal comma, vertical comma, vertical trefoil, and this is spherical aberration. Of course, this one is the highest one. So the patient suffers from some comma in the right eye, although it is still below the cutoff value. This is the left eye. The left eye, against the rule, it mimics the crab claw, somehow crab claw. And look at the type like this. So thin cornea, something not good. Chord mu is fine. Here, it is consistent. Here it's normal, some yellow. So in general, you cannot say frankly it is keratoconus. here more even, 0.564. And this is on the account of vertical comma, look, 0.43, and horizontal comma as well. So both the comma, then the comma is the problem here. So this is the right eye. Now, if you have another machine to check why this is the case, then it would be much better if you study the patient with more than one device. For example, if you study by using the epithelial mapping, corneal biomechanics, it will give you a better idea about the patient. So this is the epithelial mapping. As you see here, the epithelial mapping shows this is the axial map. This is the posterior tangential map. I use the posterior tangential map, whenever I feel suspicious, and this will give me if there is asymmetry. Here, the asymmetry is minimal, actually, on the posterior surface. So we can say on the posterior surface, there is nothing. It is all about anterior surface. So we look at the epithelial map corresponding to the same hotspot. We don't find focal thinning, okay? No focal thinning. So maybe this is because of dry eye, maybe because of using contact lenses. So always check the tear film as well, and let the patient use or treat the patient properly, and then let them come back. And this is the S39 showing here, borderline, check the other parameters, but always don't depend on, definitely on the diagnosis of the machine, because sometimes it may show normal while it's not normal. So it just gives you an idea. And here is the left eye. As you see, this is the crab flow. The posterior tangential map, concentric, there is no anterior superior asymmetry. And here we don't find focal thinning. This is thickening even. Okay, this part is thicker than the one above. So most probably this is because of dry eye. And here it is showing normal, but that does not mean that you are on the safe side to go and do refractive surgery for this patient. So what do you think, Dr. Mahanna? Do you do PRK, for example, to this patient?
Debatable. It is always advised to do surface, especially in our population. So depending on the age on this head, I would go with the surface.
Oh, she is 20 years and female. Oblique astigmatism and against the rule astigmatism.
أنا أشجع منك دكتور مازن شوي.
Sorry?
أقول I would go with surface.
All right.
أنا قلت أنا أشجع منك شوية تراني.
أشجع. Okay. طيب, okay, maybe you have experience with more experience than me in such cases, but definitely I would not touch such a patient. Of course.
An experience with the PRK مع cross linking دكتور?
No, because it is not frank ectasia. I don't do at all the PRK plus. I don't do it. And even I'm against.
Yeah, so ما أنا خارج الموضوع. Just give them دكتور whatever you believe in is right. So in this case, you would not do a cornea-based refractive surgery.
No, of course, I respect your experience as well, Dr. Mahanna.
لا اوكي بس انا اقصد احنا ما نبي نطلع beyond the norm. يعني واحد to be safe is better.
أيوه.
So
yeah.
you ask my opinion, بس ان انا I would better go with your decision. اقصد في this presentation we are يعني dealing almost اغلبهم اللي موجودين معنا في resident, فما نبي نتكلم في حالات اللي out of the box. So
yes.
better not to do a corneal based procedure for these type of patients.
Thank you very much. And this is the answer for Dr. Muhammad Jasser. Can we do cross-linking then refractive surgery? No, because this is not keratoconus. Askar says, should we consider the abnormal curvature map even through astigmatism less than 1.5 if the skewed radial axis is high and the astigmatism is less than 1.5? Just ignore the skewed radial axis. Don't look at it. Now, case number 4, 25 male, 2 to 180, 2020, 2 to 180, 2020. All right. Now look at this. We have thin, steep cornea, which looks to be normal, but thin and steep. Okay? There is some asymmetry because this one is 50.2. Here it is 48.5. So the difference is 1.7. So we can say it is asymmetric, but no skewed radial axis. And the thickness map is concentric. We don't look at the Kmax. Kmax is no evidence for it. So even if it is 50, I don't look at it. I look at the Km. This one is above the limit. All right. Now, it's very important when we see steep cornea to look at the white to white, because there is an evidence that when the white to white is short, then the cornea will appear as steep. Okay, so steep corneas are mostly associated with low white to white diameter, which is usually less than 11. 11.4 is something within the range. So less than 11, you will find those steep, but just as an information to look at it. Here, Corneal is fine. Best fit toric ellipsoid is fine. Consistent. Number is fine. The two maps are okay. Here, there is 0.542. So it is high. Now, because the cornea is steep, you may think that the patient has spherical aberration, steep spherical aberration. But this is not the case. Look at the spherical aberration, 0.184. And here, 0.184. So it is on the account of vertical comma, because it is asymmetric, vertically asymmetric, as we mentioned before. So this patient is suffering from comma. You see why it's important to study the Zernike? We come here. It is okay within normal here. Still thin. Here, asymmetric, because it is 1.9 difference. Okay. So inferior superior asymmetry. Elevation maps are normal. The shape of the corneal thickness is normal. The best fit toric ellipsoid is fine. Corneal is fine. The BAD is fine. Zernike, even more, 0.66. And this is on the account of the vertical comma. So because of the inferior superior asymmetry. Perfect. So the patient is suffering from comma. Now, thin, steep, asymmetric cornea. What would you do? Yeah. Nothing. Yes. Who else? Okay. Avoid corneal procedures. Super. So let's see if we can, because 25, maybe we can do phakic IOL. All right. So for phakic IOL, we have to go to here, the parameters. Here, anterior chamber depth and anterior chamber angle. The depth should be at least 3 millimeter internally. Be careful when you read it. It should be internal, not external. External means including the thickness of the cornea. So it will give you false deep anterior chamber evaluation. So here it is internal 3.3. Wow, that's perfect. And here the angle, it should be at least 35 degrees, at least. Why? Because when we implant the ICL in the sulcus, the anterior chamber angle will be reduced by 15 degrees. So if it is 35, postoperatively it will be 20. Of course, below 25, there is a risk of angle closure glaucoma. So always The angle should be better than 35, more than 35. So it is not only the anterior chamber depth, it is as well the anterior chamber angle. In addition, of course, specular microscopy and so on. So yes, we can not always to go for the corneal refractive surgery. Here, 30 female minus 2.5 minus 2.5 spherical equivalent. Here, spherical equivalent. We see here that no asymmetry, no skewed radial axis, number is normal, shape is normal, thickness more than 500, the KM is less than 48, perfect. By the way, if you want to know the superior inferior asymmetry, if you are a user of the pentacam, you can go to that topometric. It is called topometric. And you look at this number, IS. It will give you the difference, whether it is more than 1.4, less than 1.5, more than 1.5, and so on. Here, there is some on the anterior, but as we saw here, maybe because of the skewing, because of large angle kappa, maybe. Okay, the D is high, and of course it's myopic. And here, all is normal. This one alone, you see, until 6, then it goes down, but this is not a problem. Average is 1.1. RMS, you see, this is a mistake. Here it is cornea front. It should be this one, wave front aberration cornea, and we look at the RMS. This is the left eye. As you see, it is 1.5 difference. So exactly at the cutoff value. And here it is normal. Now look at the cornea, displaced down and temporal. If you see this pattern, displacement down and temporal, then you may think of eye rubber. The patient is rubbing because the hand comes from down temporal to the eye. So always think about rubbing the eye. And this may explain why there is inferior hotspot. IS is 1.41, so it is exactly at the cutoff value. And here, only at the anterior, some parameters are abnormal. So best fit toric ellipsoid is normal. The chord mu is fine. This one is normal, except the average. Average is 1.2. Here, nothing. All are okay, almost. There is vertical comma, of course, here, because it is more than 0.35. It is 0.36. So there is some asymmetry. There is some high order aberrations. There is, let's say, the thickness map is showing this displacement. So in this case, do you do or not? If you want to follow the rules, actually, we can do surface ablation, that's fine. But it's better to know the cause of these irregularities, maybe dry eye, maybe use of contact lenses, maybe eye rubbing. So always treat first before you do anything. Okay, now, what is suspicious about this case? Very good, Hamda. Advise not to rub the eye and reevaluate. Very good. For the previous, of course. Yes, Abdulaziz, high anisometropia here. Not reaching 20/20. Very good. Amblyopia left eye. Maybe, but a good remark. What else? How about astigmatism? What do you think about the astigmatism? Is it with the rule or against? It is against the rule astigmatism. When you see the flat minus, so flat, vertical, it is against the rule. This is vertical minus, so this is the flat. And because it is vertical, so it is against the rule. Okay, this is against the rule. Now, what about this? Is it myopic astigmatism or hyperopic astigmatism or mixed astigmatism? Mixed astigmatism. Now, how about the age? 45. All of these parameters should remind you about the disease called pellucid marginal degeneration. Let's see. This is the right eye, which has only 0.5 plus and minus 0.5 astigmatism at 90. So crab claw and the melting thickness map going down. Look at this bulging. So it's an early pellucid marginal degeneration here. Okay, look at, this is not important. Look at this. This is the left eye. Pellucid marginal degeneration. Look at the thinnest locations, down, bulging, down. So this is pellucid marginal degeneration. In pellucid marginal degeneration, always, even the patient is 45 or 50 or 60, you have to consider it progressive. Okay? We don't say we have to monitor progression because this is BMD. So you have to do cross-linking immediately. Even if you are planning for keratoplasty, do cross-linking. And the cross-linking, of course, should be decentered downward in order to cover the area of pathology. And of course, you are going to affect the inferior segment of the stem cells because the spot of UV light will come on them, but no problem because we still have about 320 degrees intact stem cells. So always do cross-linking even if you are planning to do anything else. Okay. Now this 18-year-old male is coming for refractive surgery. Not important the numbers, not important what we are going to see about the pentacam, but I want you to imagine that after asking the patient, this patient is suffering from shadows and low contrast. What's the meaning of low contrast? It means that they feel blurry vision, especially when it is sunset. Okay? Sunset, Maghrib, they start suffering because it is the time where the contrast of the things will become very low. During the day, with the sunlight, they can see almost properly, especially when the pupil will be constricted and the pinhole effect. So everything will be fine. But the low contrast sensitivity, which may happen because of irregular astigmatism, corneal haze, glaucoma, macular problems, cataract. So remember these things. They suffer from low contrast sensitivity. And of course, the iatrogenic one that we created to them when we do LASIK, PRK, or lenticule extraction. Any type of surgery on the cornea will reduce the contrast. Okay? Now, what's the meaning of this? If the contrast sensitivity is very low, the patient will suffer from minding the steps. They cannot go on the steps. They may fall down because they cannot see the difference between the two steps. And they cannot pour صب قهوة in a black cup because black coffee and black cup, so they cannot know exactly whether they are putting it in front or back. So they will behave similar to those who have low stereo acuity, low stereopsis. So be careful about people having low contrast sensitivity. All right? How to check that? Of course, if you have the machines, they can predict, they can show you. This is the point spread function that shows you how the patient sees the spotlight. They see it like this. So it's like a coma. The patient suffers from coma, this patient. Okay, this is the other eye. So what is the differential diagnosis? I already mentioned that. Any opacity in the media or after laser vision correction or macular problems or glaucoma. Okay. This is the same patient. Yeah, this is the same patient, case number 7, just to see the epithelial thickness map. Symmetry, there is nothing abnormal actually. The comma is 0.49, but because this is Cyrus or MS39 CSO, so up to 0.5 is normal. Here, the RMS altogether, it is just above the 0.5. So some comma effect. This is comma effect. And the diagnosis of the machine shows borderline in the right eye. Okay, so the right eye, almost fine, but the patient is suffering from shadows. So why is that? There is no glaucoma, no cataract, no macular problem. The patient is still young, no congenital diseases. So what do you think? Large ankle kappa? No. Low order aberration? The low order aberration are associated with myopia and astigmatism, so they do not make the contrast sensitivity low. No, they do not affect. What was the most important question that I started with in the beginning of this presentation? Exactly, Abdulaziz. Very good. What about the left eye? We do not give answers until we see both eyes. This is the left eye. Keratoconus, as you see. Comma, very high comma. Keratoconus. Okay, now let's move. Do you have any questions so far? No questions. Why you depend on Kmax of front map, not the third box? No, I don't depend on Kmax at all. There is no Kmax of the front map. Okay, let's see one of them. Okay, this one. Kmax here, the third box, Kmax is the maximum K on the anterior surface, on the anterior corneal surface. Okay, but I do not depend on it. You mean K mean. If you mean the K mean, because this is the one that has evidence. All right, there is an evidence about the cutoff value. Rabinovich described the cutoff value for placebo-based instruments, 47.2, while Jack Holliday described the cutoff value for K-mean for the pentacam, and it is 48. Okay, any other question? Of course, you can ask, no problem, anytime. I can stop and answer the questions. Now, this one is 35-year-old male, already has keratoconus, but feels deterioration of vision. Eye exam showed insignificant changes in refraction over the last year. So same refraction. So let me go back to our question. Can low myopia cause low contrast sensitivity? No. Contrast sensitivity, opacity in the media, glaucoma, macular problems, post laser vision correction. Remember those causes. So not the refractive error itself. The refractive error itself will not cause anything. Okay, back to this case. So already there is keratoconus. Now, here is the question. Is the patient malingering that, okay, I'm losing vision, but we checked vision and it was nice. Okay, maybe the keratoconus is progressing and we should not depend on the changes in vision because we know that in keratoconus patients, there is intra-observer and inter-observer variations. If I do the refraction for the same patient now, after 5 minutes, maybe every time I will get a result. And if I do it for this patient now, and my colleague does that for the same patient after 15 minutes, we will get different results. So fluctuation, diurnal differences, and so on. So we should not depend on the measurement on the refraction on both sides. If it is stable, we cannot say it is not progressive. And if it is not stable, we cannot say it is progressive. Either side, we cannot. Let's see the topography. This is the topography of the patient in February 2022. Right eye. Now look, right eye after a year, before a year, after a year. You see, maybe some changes, small changes, minor changes. You may say, no, it is stable. And let's see the left eye. 2023 and 20. So this is 1 year before, 1 year after. So you can say similar. You see, for example, look at this number. It is 35 here. It is still 35. Okay. Here it is 46.5, as you see here. And now 46.5, 1 year difference. So according to the pentacam, there is no change. Now, do not depend on that to take the decision. If you have pentacam, just use this one. What is this one? This is the Bellin ABCD progression display. This is parameter A, parameter B, parameter C, and this is for the vision. Ignore this. Now, this is A in 2022, and this is A in 2023. Look at the change in parameter A, 2022, and here, 2023. So there was a change. Now look at B, minor change. Look at C, there is a change. Okay, so to say progression, there must be a change in two parameters, beyond the 85% flag. You see, this is the 85% flag. Sorry, 80% flag. So this one is beyond, and this one is beyond the 80%. So both parameters went beyond. So there is a progression. Or maybe you will find only one parameter that jumped beyond the 95%. This one. Anyone that jumped beyond the 95%, even if it is single one, then there is progression. So either two beyond 80 or one beyond 95. So in this case, two beyond 80. So there is progression despite what we saw. Now there is a question from Hamdan. What is A? It is the radius of curvature of the anterior surface around the thinnest location. What is B? It is the radius of curvature around the thinnest location on the posterior surface. What is C? Thinnest location. Okay, so what would you do? So now it is progressive. And the patient says, I'm losing vision. Do you do cross-linking or not? Of course, this is debatable. But since, no, there was no cross-linking before. Because the patient is feeling losing vision and we documented there is a progression, then we have to do cross-linking for the patient, even with the age of 35. Because it is not written on a stone that the keratoconus will not progress after age of 30. Okay? It is not shay munzal, and after 30, no progression. Since there is a documentation of progression, do cross-linking, even in this age. Perfect. Now, this is a case for cataract. Just as you see, step by step, from normal, suspicious, abnormal, and so on. Now we are coming to a different category, which is the cataract. Okay, this patient is coming for cataract. So why should I do topography for the patient? Who can answer? Why I must make topography for cataract patients as one of the checklists, one of the categories in the checklist. It is a must. Who can say why it should be? IOL selection, very good. If I need toric or not, EDOF or not, very good. To know if the astigmatism is lenticular or corneal, very good. Corneal astigmatism and toric IOL, super. What else? You see, all your answers are perfect and means that we need it. We need the topography. It is not luxury. Yes, main incision, to know where to go through the main incision. If any needs for intra-op astigmatic correction, very good. So all about astigmatism, incision. Okay. Moreover, what if the patient has keratoconus and you did not discover that, and you did a beautiful cataract surgery, and you put a beautiful lens, and then the patient starts suffering just because the patient has irregular cornea or keratoconus. So how you are going to explain that to the patient? I'm sorry, you have irregular astigmatism that we did not pay attention to it before the operation. This is one point. The other point, what if the 60-year-old patient had previous laser vision correction, post-myopic correction, post-hyperopic correction, post-astigmatic correction? So the cornea is no longer normal, and therefore the biometry is wrong, will be wrong. Like in this case, this patient is post-myopic treatment. Post-myopic treatment. Okay? So we cannot use the usual formulas in order to calculate the IOL. This is the left eye. Now, how do I know that? You go to the tangential curvature front. You see there is a contour, hudud, limits of the ablated zone. Look, this is flat area, flat. This is steep area. So the cornea was ablated centrally, which means that previous myopic treatment. So this patient, post-myopic, and you confirm that by another machine, another map. This is for the left eye, of course, which is the relative pachymetry map, because it shows exactly the area, ablated area. Look, the minus is in the center, plus at the periphery, means ablated tissue is in the center. This is the other eye, minus in the center, plus in the periphery. So the cornea was ablated centrally. So it is post-myopic. The patient is suffering from some high-order aberrations. So of course, trifocal, no. Look at this, the other eye, 0.8. All right, so even EDOF is no in this left eye. How about Corneal? This is a must, especially for the cataract people. So Corneal is very important. Here it is normal. It is 0.41, so just below the cutoff value, which is 0.42. What else we should check for the patient? What do you think? Before doing the biometry. Yes.
بدنا نصحصحهم شوي دكتور مازن.
Okay, place an answer. يلا. Okay, high order aberrations. We have seen them. This one and this one. What else? It seems that I'm going to ask one by one. So, Talat, what do you think? Oscar said refraction. Okay, good. Abdulaziz, radius of curvature, anterior chamber depth. Okay. Talat. Majid. Rasha, specular, good. Okay. Aisha. Fundus, okay. Rasha, Fundus. Ragad, Saad, Abdullah. All right. The tear film is very important. If the patient has dryness, forget about the biometry. Treat dryness first. Otherwise, wrong measurements. Okay? Type. Now we come to the best formula. What is the best formula for keratoconus people and post-laser vision correction people? What is the best formula? Okay, if you have some suggestions, let me know. رأي دكتور مهنا تشوف مين اللي عم يجاوبوا أكثر شيء to give them presents صراحة أو
المشكلة أن I'm sure that they know يعني we just discuss it يعني مش بعيد. إذا جاتك هلت الأسئلة جوهرات.
Barrett, Hofer Q, Hages or Barrett, Laser Hages, Barrett through K, Kane, Barrett, Kane, Hages. Okay. Now, I'll tell you the latest study, actually, the latest study. This one. Barrett through K, yes. If the patient has keratoconus, you put for keratoconus. If post myopia, you put myopic, and so on. But you should use the MPCA. Now I'll show it to you. It will be better than using the PPCA. We will see it now. Now, if you don't have an access to Barrett, Kane for the keratoconus is very good. But you cannot use Kane for post-laser vision correction. So you must have an access to Barrett. Now, I'll move the window to this one. This is live from the internet. So you can see what I'm going to do. This is Barrett. Okay, fine. Now, I will come here. This is post-myopic. Great. You can see hyperopic radial keratectomy or keratoconus. We are with myopic. And here we are with myopic. All right, fine. Now, we put what we have. So the axial length for this patient is 25, for example, assuming that patient had myopia, axial myopia. Measured K1, let's assume it is, let me take it from here, from the patient himself. After treating his, of course, dry eye, it is 40.8, 40.8, and here it is 41.1. Optical, by IOL master, for example, it is 3. Target refraction, nothing, keep it as it is. White to white here is 11.7. You have, even if you want for one eye, you have to put for both eyes, otherwise it will not work properly. So 25.1, and for the left eye, it is 41.2, 41.8, optical ACD 3.1, for example, and white to white is 11.8. All right, now I'll tell calculate. When I put calculate, sorry for that. When I put calculate, you will see something here, will appear here. Doctor name. Okay. Patient test. Here, no financial interest. Let me just select this one. Okay. Calculate. You see, it opens these two. Either you take the predicted posterior corneal astigmatism or the measured posterior corneal astigmatism. As we mentioned before, the measured is more accurate than the predicted. So put this whenever you put this, it will take you to another page. You see? Now, in this page, if the patient has keratoconus, you put keratoconus. Otherwise, you keep it like this. And if you are taking those that we are going to see from the pentacam, you have to put pentacam. All right? Type. Now, because I'm taking it from pentacam and it is post-myopic, so I'm not going to use pentacam keratoconus. I'm going to use this one. Then I will come here. I will take these numbers from the posterior surface, posterior cornea. From where I will get that? Look at this. Just 1 second. So here, the cornea back. You see the cornea back? You just put the K1, K2 from the back, you put it there. Okay, let us see. So I'm going to put the keratometry. The keratometry here, the flat K is minus 6.4, but it should be in without minus. Okay, you put it as a number, 6.4. And the steep K, it is 7. You go to the left eye, for example, let's assume it is just the same, 6.4 and 7. Optional, so I can put it, for example, for 500. Here, 500. Okay, so outside the range, yeah, it should be because 0.5, sorry, 0.5. Now, when I say calculate, it will calculate the measured ratio, posterior to anterior. You see, posterior cornea, it will show the ratio. I don't care about it, but it is doing its own calculations. Now, I can go to this one, universal formula, to see the, sorry, this one, calculate, universal, yeah. Here is the number. You can, of course, target your patient 21.5, whatever. Okay, so using the measured PCA. So I think it's clear. You can watch the video later and see how to use it. This is the latest article or study showing that this is the best. And of course, if you want to go for Kane, it's so easy. Kane formula. I agree. Then you can use it. You can, of course, if it is keratoconus, you put keratoconus, and then you put all the input, and then you do the calculation. All right? So it is so easy. All right. Now, going back to the presentation. And this is the last case, which is also cataract, just to highlight the importance of pupil. 65-year-old female, cataract, irregular cornea. So which one to go for, trifocal or EDOF or enhanced monofocal? As we said, we have to look at two things. The RMS is high here, and chord mu, it is normal here. And of course, the pupil size. Always take the average of the mesopic and scotopic. Take the average of them and check. If it is 7 millimeter and above, the patient will never be happy with a trifocal. Will never be happy with a trifocal. Even the EDOF, I have some patients who are not happy because their pupils are even 6.5. The average is 6.5 with the EDOF. They are not happy. I'm just putting them on the alpha-GAN just to constrict the pupil a little bit to make it better for them. Okay, so this is what I wanted to say, and thank you very much. والسلام عليكم ورحمة الله وبركاته.
عليكم السلام، يعطيك الف عافيه دكتور مازن. فيري انفورماتيف كالعاده، الله يعطيك العافيه. and very يعني طلعت من جو محاضرات وصارت يعني زي القصه، ما هي زي المحاضره الفورمال. في هنا سؤال من الدكتور مصطفى عن about الهيجز. Do you use it for post laser treatment?
No. Always for post laser, Barrett through K measured PCA, always. And it is available online as you saw. So forget about all other formulas, all. And I'll tell you something else, just 1 second. For the formulas,
إلا ما يجوز دكتور مازن any other comment or question? ولا we conclude with the answer of this question?
No, of course, any other questions, I'm so happy to have, no problem. بس خليني أقول في just there is an information that I want to say it regarding long eyes and short eyes. Then we know when the axial length is very high or very low, there will happen some mistakes in the ordinary formulas. Let me show you this. لا إذا مليتوا بقى أنتوا.
أنا أبدا معك يا دكتور، تفضل.
Look at this. You go to this article and you will see that the best formulas for long and short. Long means 25 and above. Short means 22 and below. Okay? Type. What is the best? Kane, Evo, K6. Only. Use Kane, Evo, K6. This is for the long. K6, Evo, and Kane. So in both cases, Kane, Evo, and K6. From where you can get those? From, I'll show you. From ESCRS IOL calculator. Sorry. ESCRS IOL calculator. You see, it is ESCRS calculator. You can just untick all of them. I want just K6, Evo, and Kane. So I remove hover Q, Hill, Peel. Damien Gatinel. I want. They don't want to remove it. Okay. So maybe it's mandatory for everyone. So Kane and this one. So I want Kane, Evo, and K6. I wonder why it's like this. Okay. So you can pick whatever you like, and then you fill in, and then it will calculate it for you. Okay? So always K6, Evo, and Kane for long eyes and short eyes. So for keratoconus and laser vision correction, go to Barrett through K measured posterior corneal astigmatism. And by this, all are covered. You don't need to think about other formulas. This is the latest, and I have the article. It's a very nice article.
في more question يا دكتور. كانوا يسألون عن يعني if you need to document progression without going back to ABCD map, what parameters are you going to look for?
Unfortunately, depending on the Kmax change and the thinning of the thinnest location, this is the arbitrary one that we may use it if we don't have an access to that one. But actually, this is not accurate because the Kmax, as we mentioned, prone to artifacts. So you can depend on Kmax, of course, a change of Kmax more than 1.5 diopters and thinning more than 15 microns. At the same time, both should be together. Now,
what is the differences? Okay, تفضل دكتور. تفضل كمل.
What is the difference between positive and negative spherical aberration? There is no difference actually, but people having spherical aberration, they have depth of focus. They can see better depth of focus. This is, of course, a huge subject to talk about, but those having negative spherical aberration will have better quality of vision in comparison with those having positive spherical aberration. For cane, if it is toric, they will ask for surgical induced astigmatism as mandatory input. Is it always 0.25? Very good question, because you have to define your surgically induced astigmatism. You should know it. After you do several surgeries, you can check before and after and see whether maybe you are inducing only 0.1, for example. And this differs as well from going through an incision, upper or temporal. The temporal causes less surgically induced astigmatism.
There is a website, I think they can just go and enter
Yes.
their pre and post-op and it will calculate it for you.
For them, yes, exactly. If I have patient post-LASIK ectasia, do we use Barrett through K? Yes, as keratoconus, you consider it as keratoconus.
I think إذا فتحنا المجال الأسئلة ما راح تخلص دكتور مازن. أنت أعطيتنا أكثر من الوقت اللي نحتاجه، الله يعطيك العافية. يعني توعدنا بساعة ونص، ما شاء الله أنت عديت الوقت اللي كنا نحتاجه. شاكرين ومقدرين وجودك معنا دكتور مازن، ولا نستغني إن شاء الله بإذن الله يكون لقاءات أخرى بإذن الله.
الله يبارك فيكم، جزاكم الله كل خير، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.